I get the honor is actually of getting to introduce the next speaker. But let me tell you something really quick about myself. My name is Denise Croden. I am the twin sister of the speaker who's up next. So yes, I get to welcome Dana Winrow, and she is a PT, physical therapist, and she's a CT-LANA. She can explain what all those letters and stuff mean. But ultimately, she's a physical therapist with over 27 years experience. And she has been certified in lymphedema for about 20 years now. And she is also the mom to her son, Jonathan Winrow, who is 21 years old. And obviously, he does have Phelan-McDermid syndrome. Dana is always available, always excited, always more than willing to share all of her clinical knowledge, her day-to-day knowledge, willing to listen, answer, help however she can. So she amazes me every day. And yeah, let me introduce my sister.
Welcome, everybody. Can you hear me okay? So lymphedema and Phelan-McDermid syndrome. Denise did a wonderful job telling you a little bit about me. There's my family up there with my son Jonathan down in the corner. I am a certified lymphedema therapist. I had got my Lymphedema Association of North America certification in 2006 and have maintained it. My husband Christopher is taking care of Jonathan right now. My daughter Tori is here helping, and those are my dogs at home. All right, so we're not going to do polling. Instead, we're just going to do a little quick hands to see who's in the audience. Does your person with Phelan-McDermid syndrome have lymphedema? Raise your hand if it's a yes. What age group is your person with Phelan-McDermid syndrome in? 0 to 12, 13 to 30, and 31 plus. Have you attended a lymphedema talk before? Yes, good. And have you discussed lymphedema with a healthcare professional before? Great. That just gives me a little idea who's here. So since I've last given a talk about lymphedema with the Phelan-McDermid Syndrome Foundation, there have been some new, very useful resources added to the website. So I'm going to start by talking about what's new and what's different, and then I'll go a little bit into what might be a review for a lot of you, the basics of anatomy, physiology, and treatment, and I'll try and add in little pieces of information that are new. So there's the three resources that are available on three of the resources that are specific to lymphedema are the European Consensus Recommendations on Lymphedema and Phelan-McDermid Syndrome, the Guidelines on the Management of Cellulitis and Lymphedema from the British Lymphology Society, and the U.S. Updated Consensus Guidelines on the Management of Phelan-McDermid Syndrome. So the European Consensus Recommendations on Lymphedema and Phelan-McDermid Syndrome, what they're saying is that about 10 to 25% of individuals with PMS are approximately having lymphedema. They're saying it's not specific to the Shank3. They are saying that you're considered to be a stage 2 of lymphedema. If you go to bed with swelling and you wake up still with swelling, they're considering that a stage 2. And they see it most frequently in feet and legs, and also some in hands and arms. We've seen it everywhere in lymphedema individuals. I have people that have told me about genital swelling, face swelling, but by far the extremities are the most prevalent. The management of lymphedema continues to be compression stockings during the maintenance phase, trying to control the swelling and prevent cellulitis, and the factors that we have to deal with that can make lymphedema a little more complex are obesity and immobility. So the guidelines on the management of cellulitis and lymphedema from the British Lymphology Society, I was super excited to find this and referred it to the scientific group at PMS. When you deal with cellulitis, for anybody who's had cellulitis, cellulitis specific to lymphedema is a little more complicated. Because of how poor the circulation is and the fluid being trapped in the tissue that keeps kind of feeding, the bacteria keeps kind of feeding the cellulitis. When we deal with cellulitis and lymphedema, the antibiotics and the exact course of treatment are slightly different than a typical cellulitis. So this is a resource that you can print out and bring with you to the emergency room or to your physician. And they have some really good recommendations about types of antibiotics to use, how long to use them for. Again, it's not everything, but it's an amazing resource. I treat lymphedema currently. I treat lymphedema in an outpatient clinic as well as in people's homes, and I'm still doing that now. And I still tell people to use this resource, even for individuals without PMS. The third resource on the Phelan-McDermid website is a U.S. consensus guidelines on the management of Phelan-McDermid syndrome. So this was discussed and presented earlier in the conference. I had the privilege of being on one of the small groups to help with it. But under the physiatry section or the rehab section, they are making recommendations that you address lymphedema with exercise, healthy body weight as possible, compression garments, and try and really manage the amount of fluid and slow down the disease progression. So it is now part of that big, wonderful resource to bring to your doctors about things to look out for in somebody with Phelan-McDermid syndrome. So I'm going to try and go into a little bit. Hopefully it's not too much of a review for people, but I'm going to start at the very, very basics. I was just speaking with somebody that I first spoke to at a conference at PMS in one of the ones in Florida, and she said that she brought the idea of lymphedema to her doctor. So I really think it's important to kind of give you guys the information of what lymphedema is. More and more physicians are being educated on it. I'm a physical therapist that treats lymphedema, and I can tell you when I went through my training at university, I did not get any education on lymphedema. It was my continuing education that taught me what lymphedema is. So lymphedema is a permanent condition that develops when fluid collects in the tissues and results in chronic swelling. It most often occurs in society when we have damage to the system later in life, so due to injuries or surgeries. But a poorly developed lymph system or venous system at birth can result in lymphedema, and that tends to be the category the Phelan-McDermid syndrome individuals fall into mostly. Who gets lymphedema? People with damage or improper function to their lymph system can get lymphedema, but not everyone does. So we call you at risk when you have a lymphatic system that's not typical. So right now, it's kind of an interesting thing because unless you know your lymphatic system is damaged, you don't know whether or not you're going to get lymphedema. And we'll talk a little bit about how to find out if you have lymphedema or are at risk for lymphedema. So if you are at birth, have a lymphatic system that's not formed typically, then you can have congenital or primary lymphedema, but that doesn't mean you're going to see swelling at that point in time. Or if you have lymph node removal, trauma, or surgery later in life, you can have secondary lymphedema. When you start to swell is when the swelling is the lymphedema, when your body can no longer remove all the fluids it has transported into that area. So going back a little bit to some of the information from PMS, this is just a snapshot of when I asked for information. So even as of today, that this information be out of date. So as you know, we have the Phelan-McDermid Syndrome International Registry. They'll often ask you to put in, takes quite a bit of time, but it's super, super useful. But we ask people to put in their information of all their medical information into this registry. And we can pull out of it things like this. We know that at the time that I tapped into the registry, there was 7.5% of the people had lymphedema, 83% of them were primary lymphedema, and 17% were secondary lymphedema, with the average age being diagnosed at 11. Two other articles that have reference to lymphedema. 7% of the people were showing deletions related to lymphedema, and they weren't necessarily related to Shank3. Another was showing 24%. And so just there's starting to be more and more information. We tend to be hanging around the somewhere between 7 and 25%. I do think that that may change slightly. I think as we get the better understanding of what lymphedema is, and as the physicians understand better what lymphedema is, we might get a little bit more people being diagnosed. And as we start to develop genetic markers and things like that, we might see a little bit higher prevalence. But it seems to be between the 7 to 25% at this point in time. So going back into what is lymphedema. The lymphatic circulation, it helps nourish all the tissue in the body. We have more fluid coming in and nourishing the tissue at a quicker rate than it is coming out. So then it backs up and you get fluid deposited in the tissues. And that's what lymphedema is. The lymphedema is the abnormality of the lymph system. The fluid that is stuck there, or the stagnant fluid, is a thicker fluid. It has a lot of protein and cellular debris in it. The lymph is your transport. Your risk of lymphedema doesn't change. What we try and do is help you to manage lymphedema, because we don't repair your lymphatic system. We don't repair the congenital abnormalities. We don't give you new lymph nodes. We'll talk a little bit about some treatments and what the ideas are behind them that they're trying to evolve. But lymphedema is a progressive disorder because your lymphatic system keeps trying to manage the fluid that you have. And what they keep trying to manage as you get older, your system can wear out. Also, as we all get older, all of our systems kind of wear out. So that's why it's a progressive disorder. So primary lymphedema. For people that have a lymphatic system that is not properly formed from birth, what are some possibilities that they're saying is happening with primary lymphedema? Lymphatic vessels have valves in them, so they have little valves that come together inside the vessel that kind of help push the fluid upwards, and they also prevent the backflow of fluid. If you have vessels that are too large, you're going to have valves that don't touch each other, so fluid's going to kind of go backwards. If you have smaller vessels than you're supposed to have, you're not removing enough fluid. The wrong number of vessels, if the vessels aren't transporting the fluid the right direction. So these are all things that are possible with primary lymphedema. We're not sure at this point in time what could be the cause going on in Phelan-McDermid syndrome. Secondary lymphedema is an obstruction or injury to the lymphatic system. So this can happen for anybody, but as you can see, it can also happen for individuals with lymphedema. They could have damage to their system at any stage, and that could they could have primary and secondary lymphedema, or just secondary lymphedema. So why do we have a lymphatic system? Like I said, we all know about our circulatory system. People kind of ignored the lymphatic system for a long time. We're now spending a little more time in education on the lymphatic system. The first function of the lymphatic system is it removes the larger proteins from our body. Your blood and your circulatory system focuses a lot more on the water content and the fluid. The second is to move fluid. It helps with the moving of fluid. And the third is part of your immune system, and it identifies substances that do not belong and attaches to them and destroys them. So the lymphatic system is a system throughout the whole body. It circulates to all the tissues and in between the interstitial spaces. 90% of the fluid is reabsorbed by the blood and the tissue cells, and 10% is left behind. The lymphatic system drains excess fluid and protein. It's a different trans system than blood or the circulatory system, and when fluid is not draining properly, you have lymphedema. So how does our lymphatic system work? Our lymphatic system works a little bit differently. Our lymphatic system likes to work in sections. And so we have lymph nodes, and we kind of think of them as the drains. All the teeny little vessels go from little microscopic vessels to bigger vessels, and ultimately try and drain and get filtered through the lymph nodes, which eventually get deposited in the left side of the heart, and then the excess fluid that we don't need is excreted in the urine. The sections of our body are above the collarbones, above the clavicles, and the head and neck. The head and neck lymph nodes drain that whole area. Between the collarbones and the umbilicus, or the belly button, we divide the body in half, and the right armpit drains the chest, front and back, and top of the abdomen and the arm, and then the left does the left side. From the belly button downwards, again, we divide the body in half, and the right groin does the lower abdomen, part of the back, the genital region, and the leg, and the left on the left side. So because of this, the reason this is interesting is that when you see people, they usually have asymmetrical swelling because each kind of section kind of works by itself. So even if people have both legs, they tend not to be the same size. One leg might have more swelling than the other leg, and that might be the case always, especially with a primary lymphedema. We don't know what the lymphatic system is doing. So the stages of lymphedema. The first stage is called the latency stage, and again, not everybody knows if they have a latency stage, but what happens at that stage is the lymph system isn't properly formed or not properly functioning, but we don't notice anything. The body's taking care of it. Stage 1 is called spontaneously reversible. You might see little bursts of swelling. Often by morning, the swelling's gone, and the body just, again, plays catch up a little bit. Stage 2 is spontaneously irreversible. The swelling can fluctuate, but it never kind of goes away. And stage 3 is called lymphostatic elephantiasis. In stage 3, you start to feel really hardening of the skin, sometimes some extra growths on the skin, some skin changes to touch and to feeling, and some progressing of the lymphedema. So do I have lymphedema? So the early signs and symptoms of lymphedema, from what you can see as a caregiver and what your person with PMS can tell you, is swelling that comes and goes. Your skin feels or looks like it's tight and pulling. Some things that used to fit, again, we're looking at a specific area of the body, not the whole body. Like clothing and jewelry starts to feel really tight. Sometimes you also don't see like tendons and vessels as well as you normally do. If the person's able to tell you, they're getting numbness and tingling, or pain, achy, and heaviness. Again, you're looking at what information you can gather. If you are noticing these signs of lymphedema, then it's time to be helped by a medical professional to help you decide. So these are all examples of lymphedema. In this particular group, nobody has Phelan-McDermid syndrome. They're textbook examples. So this is a left leg that has lymphedema. This is a left foot that has lymphedema. You can see how it's a little bit puffier and into the toes. This is an example of a stemmer sign test that I was telling you about earlier from the European guidelines. So this person has a negative stemmer sign on their left. You're able to pinch the skin together and lift the skin. If you try and pinch the skin on the right, your thumbs and your fingers will not come together, and you won't be able to pull the skin up. So that's a positive. There'll be a positive stemmer sign. It's literally a pinch test. This person has lymphedema in their hand. This person has lymphedema in their arm, and this person has in their quadrant, in the left leg quadrant. So this is a Phelan-McDermid individual. In the picture, this individual is 29 years old, and he is showing signs of swelling. You can see that he's got the same puffiness in the feet. The bones in the ankles are not easy to see. There's a little bit of what we call an overhang. The fluid is kind of making the ankle wrinkle and go overhang over the time. And so a lot of people will also have, with Phelan-McDermid, some people have nail changes, but with lymphedema, you also get toenail changes as well. This is an individual with Phelan-McDermid syndrome who does not have lymphedema. In this picture, this individual is 19. This, you can see the bones in the ankles, you can see the tendons, you can see all the joints, and the toenails are a little bit flaky, but not the same discoloration as the other individual had. This person does get red and puffy sometimes, like that kind of blotchiness that some of our individuals with Phelan-McDermid syndrome have, but they do not have swelling, and they do not have lymphedema. Okay, I think I have now lymphedema. Now what do I do? Okay, so I'm going to go through some different pieces of information of who to find and how to find them, and so we'll try and answer all the questions that we have. So the first thing you want to do is discuss it with a physician. As I said, the medical world is getting better at understanding lymphedema, but you want to say, I think I have lymphedema now, what do I do? You want them to discuss your medical case with you and see if you have any other medical causes of swelling or things that could cause swelling. Even if you still think you have lymphedema, you want to make sure that those things are looked at and taken care of as well. If you get a prescription for a lymphedema, this talk has a little bit of a North American tilt to it, but for the North American community, if you get a prescription that says lymphedema evaluation and treatment, then you can take that with you to a lymphedema therapist. So we used to say that you can't do anything for lymphedema, but we're showing more and more that you can help prevent the progression or at least slow it down by getting treatment for lymphedema. Who do you contact for a medical professional? Anybody who can write you a prescription is fine. My suggestion is to go to your go-to person, whether that be a developmental pediatrician, if somebody's helping you with your cellulitis, if you see somebody for vascular abnormalities, if you have swelling related to cardiac issues. You want somebody, whoever you want to write the prescription will be approved by insurance, but you want them to be able to monitor your medical needs while you're getting treatment for lymphedema. And you want them to be able to work with the lymphedema therapist in running any tests that you think that you might need, and they will be able to help you work through that. So what is a lymphedema therapist? Again, by North American definition, but also some similarities in other countries as well. In North America, we have what's called the Lymphedema Association of North America and the National Lymphedema Network, but they recommend that your lymphedema therapist have 135 hours specific training of what's called complete decongestive therapy, or CDT course. And then at the end of that training, they will write a quick test after they finish the course, and if they pass, they'll be a certified lymphedema therapist. Most of the courses require that you are a medical professional in order to take the course, and the reason they do that is because they're expecting a certain amount of anatomy, physiology, pathology understanding before you take your lymphedema certification. A certified lymphedema therapist can then go on to write the Lymphedema Association of North America exam. All the schools in North America kind of got together and said, how do we make sure that once you become a CLT, you keep up with your training? And they have a whole credentialing. And so you can go on to be LANA certified, but it's not required. If you have the CLT training, you have a specific amount of knowledge. If you are from somewhere not in North America, a lot of the lymphedema associations will have Find a Therapist on their websites and teaching you how to find somebody that has the expertise. And if you can't find somebody, you can reach out to me and I will help you. So find a lymphedema therapist. Big thing is make sure that they have, you can take a lymphedema course anywhere from a couple hours. See that they have a certification or at least a lot of training. Make sure they're comfortable with the type of person that you are. If you have primary lymphedema, if you're a certain age group, sometimes pediatric, sometimes adult. And there's a lot of great websites and support groups online that will give you some information as well. So how is lymphedema diagnosed? So lymphedema can be diagnosed most commonly, I would say, by somebody coming to a lymphedema therapist with their medical history and the testing that they have had done at that point in time, and the therapist using their hands-on skills to look at the tissue and use the medical history to come up with a diagnosis. It is not often necessary, not always, but it's not often necessary to go for further medical testing. Sometimes we will work with the doctor to request some, but there's no definitive blood test that says you have lymphedema. So we're looking at all the information and pulling it together to see if you have lymphedema. So what the testing that can be done and what it tells you. There is soft tissue imaging, like MRIs, CAT scans, and ultrasounds. They will show fluid. So then we know there's fluid somewhere. Lymphedema vessel imaging, this is actually a test where they inject dye into your lymphatic system, usually between your fingers or your toes. It's very, very painful and uncomfortable, and it runs dye through the lymph vessels so they can look for blockages and stuff. It's still not done as a diagnostic for everybody. It's often done with research, and sometimes it's done at lymphatic centers, but it's not always necessary to be done. I don't send people for it. I don't know, out of the people that I seen in the last year, maybe one has had lymph vessel imaging. Volume measurements, looking at changes in volumes of the area, the hand, the leg, the arm. Electric conductance, genetic testing, we'll talk a little bit about that. Vascular imaging, they're looking for blood clots, how good your arteries and veins are circulating. X-rays, blood tests, they're looking for, again, other things that can cause swelling. Bioimpedance, they're looking at how much protein is in your tissue, because lymphedema is a protein-rich fluid. So what causes the swelling are they ruling out? So all sorts of things can cause swelling: cardiac, renal, pulmonary, blood clots, infections, surgeries, injuries, poor circulation, certain medications cause swelling. So that's why we have a medical doctor often involved, or we want collaboration between a therapist that's not a medical doctor and somebody that can look at the rest of your medical history. This is an example of an individual who has cellulitis. It's not quite good to see the redness in it, but they're red and puffy. And you can see their big toe is also irritated and maybe has an ingrown toenail. Oops. Back. All right, so lymphedema treatment centers, when I started treating lymphedema in 2003, they really were not around. So more and more of them exist now. There's a I'm in Massachusetts, there's the Boston Lymphatic Center. Boston Children's has a component of lymphedema. There's a lymphedema center at Children's Hospital Philadelphia. Stanford Medical Center has a lymphedema center. So do you need to go to a lymphedema center? We are complicated individuals. You may go to a lymphedema center, but again, the majority of people I see come in, they have swelling. I can tell they have lymphedema. I go through their medical history. Unless something complicated is going on, or they're really searching for additional treatments or to help sort out their treatments, I don't send them to the lymphedema center, but I encourage anybody that wants to go to one. The lymphedema centers have a medical component, a surgical component. They can do more imaging. They also will tend to send you back for lymphedema therapy with somebody like me. And so you don't get to avoid, unfortunately, lymphedema treatment, but they do have some other resources there. They're often affiliated with any research that's going on, and they'll be able to help you answer some more complicated questions. So I'm going to go a little bit into treating lymphedema. I'm going to talk a little bit about some other things at the end that people are looking at for treatment of lymphedema. The gold standard for treatment of lymphedema is still complete decongestive therapy. So the hands-on treatment of trying to move the fluid out of the tissue and keep it managed. And even when we start to talk about things like surgeries, medications, things like that, they still want you to get CDT, or complete decongestive therapy. So there hasn't been the jackpot yet to say, take this medication and then you don't have to go see a lymphedema therapist. Unfortunately, they're still requiring that component of treatment. So the goals of complete decongestive therapy are to decrease the swelling in the area, improve the congestion of the area, reduce this hardening of the skin and help the skin function, help the patient to function and move better and relieve any discomfort and improve quality of life. That's why we do complete decongestive therapy. So the components of complete decongestive therapy, most of them are done you don't need all the steps of CDT. The lymphedema therapist will decide which steps you need and which steps you don't need, or which ones you can tolerate. Manual lymphatic drainage is a technique of skin stretching or massage. It's not traditional massage that tends to increase blood flow and relax muscles. It's more working on the surface of moving and directing the fluid around blockages towards lymph nodes, helping the area that's congested to remove the fluid. This can be complete decongestive therapy is often broken into the treatment phase and the maintenance phase, and they kind of flip-flop back and forth. The treatment phase usually means you're working with a therapist who's working with you hands-on at that particular moment. The maintenance phase usually means they've told you to do a whole bunch of stuff at home, and then you kind of flip back and forth. As you need help, you come back into the clinic, and then they teach you more things that you can continue at home. So manual lymphatic drainage can be done by a therapist and can be taught to be done at home. Sometimes we use bandaging to help put a little bit of pressure on the tissue so that it encourages the fluid to be reabsorbed. It is bulky. It is layers of cotton and foam and bandages. These are not ACE bandages. They are called short-stretch bandages. The ones that you buy in the CVS or the pharmacy tend to be elastic bandages. These are lymphedema bandages, and they're not quite as elastic or compressive, and that's very important for how to compress the tissue and not damage the tissue. Lymphatic exercise is one. We're looking at lymphatic exercise. We're looking at rhythmic motion of all the joints. The joints need the muscles to move to help push on the vessels to push the fluid. And so swimming, walking, biking, like some of those rhythmic motions that are using all your joints, just moving, sometimes somebody can help you with passive range of motion as well. Skincare is important because the skin is the place where most often damage to the skin leads to infections. Sometimes if you have a ton of fluid, you will actually leak fluid through the skin. So taking care of the skin is part of complete decongestive therapy. Some people are put in a compression garment. Again, this is super tricky if it is tolerated. They can be anything from custom-made garments to things that you buy at an athletic store. And there's a new thing, if any of you have heard of the Lymphedema Treatment Act. As of January 1st, 2024, in the United States, Medicare approved compression garments, and that is a huge deal because if everybody was paying for these out of pocket. With this ruling, they do not require a diagnosis as to why you have it. There's no cause. You don't have to have a particular cause in order to get covered. You just have to be diagnosed with lymphedema. For those individuals not on Medicare, most people's insurances gradually follow Medicare guidelines when they create guidelines. So if you've been paying out of pocket for compression garments for a long time, it's a good time to bug your insurance company and find out if you can get any coverage. Again, this was just started in January 1st of 2024 that they agreed to pay. Some people, but not everybody, uses what's called a pneumatic compression device or a pump. So the idea of the pump is that it is acting like a massage to direct the fluid out of the legs. So for our individuals, sometimes this can be super helpful. They don't sit still or for a nice gentle massage, but sometimes they'll tolerate being put into a pump. Pumps can be set at all different levels of compression, and they can be used for different things. When we're using them for lymphedema, we tend to set them anywhere between 20 to 60 millimeters of mercury, and it's really dependent upon the feel and the response of the tissue. So it's really important that your therapist is involved in this. If you dial the compression to higher than 60 millimeters of mercury, you're no longer working on the lymphatic system. Sometimes you're on the venous system or other parts of the body, but you've kind of gone through deeper in the tissue. So if it's specific to lymphedema, it's usually between 20 and 60 millimeters of mercury. I like to say for vessels are kind of like garden hoses. And when a garden hose bulges, we put a little bit of pressure on the outside. That's our compression. If we pinch it too tight, then we're like cutting the hose off. We're pinching the hose off. So we're just trying to figure out what that pressure is to help direct the fluid. Oops. Where am I going? Oh, I'm going the wrong way. Sorry, guys. Okay, what else can I do? So these are things just to try and keep the body under the best control that we can. This is specific to the area of swelling. Try not to have an injury or trauma to it. If you can reduce the amount of needle sticks you're getting in that area is good. Using lotion actually decreases the amount of bacteria on your skin and makes it less favorable for getting infections. Good skin care and nail care. Try not to cut your own cuticles. Again, it just is an area where bacteria can get in. Using sunscreen and insect repellent. Be careful if you're using razors because just that they're not causing irritation and openings in the skin. If you have swelling in the hands, try and use some protection like gloves so you're not causing injuries to the hand. If you do get scratches or punctures, try and keep them clean with soap and water and sometimes an ointment. For lymphedema, you can use a podiatrist to cut the toenails. If you have athlete's foot, it's really important to treat that as well. Again, it's an area that can cause infection and lead into cellulitis infections. If you do have a cellulitis infection and you have not seen one before, you often become bright red, hot, warm to the touch, and sometimes you don't feel well. It's not something, unfortunately, that we can wait 24 hours to treat because it can enter the bloodstream and become extremely critical quickly. So if you're seeing it, you kind of need to address it right away. If you are somebody who gets repetitive cellulitis infections, some people will even be prescribed a prescription that they can access at their pharmacy before calling a doctor. So that's something just to keep in mind. Try and keep your body part moving. An active lifestyle. Again, that muscle pump. Try and avoid like tight socks or things that are too elastic that cause that indentation or constriction. If you need compression garments, use them. Fitness and weight are important because we talked about obesity being a risk factor and immobility. The weight control is important because your lymphatic system is one size. If you change and have excess tissue in the area, you're still a system that's already having difficulty has more surface area to take care of. Exercise, again, swimming, walking, biking, rolling, crawling, anything that's causing a rhythmic motion. And as you can see, the person at the bottom is helping get some mobility for that individual. Research. All right, so what else can we be doing, or what is being done to help with lymphedema besides us struggling along to be good caregivers? Diagnosing lymphedema by blood test. They're working really, really hard at finding if there is something that can say you have lymphedema. Identify a protein, all sorts of research is being done. They're looking for genetic markers to diagnose lymphedema. So one thing that I saw was for Phelan-McDermid syndrome, there was a study that was done and published, and it saw that people with a deletion in the CELSR1 gene had increased prevalence in Phelan-McDermid syndrome of having lymphedema. So it was a study done on 404 people, and 5% of the people in the study had lymphedema. So the recommendation from that particular study was that anybody who has a deletion greater than 4 megabases or that gene should be assessed by a healthcare professional for lymphedema. Another study that is being done on medications, this was not done on somebody with Phelan-McDermid syndrome. There was a study done from Stanford Medical Center, and it was using trying to look at medication to help with lymphedema. They looked at a non-steroidal anti-inflammatory called ketoprofen, and it affected the inflammation of leukotriene B4. And what they found was the individuals that were taking this anti-inflammatory noticed a softening of the skin and a decreasing in the inflammation. Again, I haven't seen how prevalent this is, just looking at a couple studies to see what was most recently done in the literature. As far as surgery goes, there are starting to do a few surgeries. Again, I know of no one with Phelan-McDermid syndrome who has done this, but when they've noticed a depositing of large amounts of tissue, hardening of the skin, from the lymphedema treatment centers, one of the surgeries they're doing is they will do sometimes a 2-part surgery. They'll go in with a plastic surgeon and they'll do what's called a debulking. And what they'll do is they'll take away a chunk of tissue that seems to be hardened tissue, not related to anything functional, and try and reduce the lymph size by taking away that tissue. They then have a microsurgeon come in, take healthy lymph nodes from somewhere else in your body, and move them to that area and reattach microscopically vessels to try and improve the lymphatic circulation. So this has been done. It is very, very selective, as you can imagine, the criteria. But this is something that if you wanted to investigate more, the lymphatic treatment centers would be the places to talk to. So effective management keeps going back to the complete decongestive therapy of lymphedema to try and control the swelling, try and decrease the progression, try and work with a therapist. Again, it's a chronic condition, so most people that I have seen, they become regular customers of mine. They come and go. Whenever they feel that it's out of control, they come back and see me and see if I can help them with a tune-up, give any suggestions, change their compression garments, see if the vendors have come up with anything new and exciting that might be appropriate for them, and then they go back to self-management again. So this is specific. I made the slide specific for Phelan-McDermid syndrome. Our kids get swelling, and it's not always lymphedema. So some kids will get swelling with blotchiness and discoloring with standing, not related to lymphedema. Our kids have cardiac and pulmonary issues, which can cause puffiness and whole body swelling, not related to lymphedema. Compression, we get compression for different things. Sometimes we'd use Theratogs or things that will help the muscles work a little bit better. Again, it's the person is being compressed, but not because they have lymphedema. We know that a lot of individuals have hypotonia and low muscle tone, so we know the muscle pump isn't always working. So just because the muscle pump isn't working, you kind of get a pooling in an area. Again, that swelling doesn't mean the person has lymphedema. Some individuals have lower mobility, and they'll often use a tilt table to go from a horizontal position to a vertical position, and when that happens in physical therapy, you do get a massive rush of fluid. Again, that will be a swelling, and it is not lymphedema. So these are questions that I've had, old questions, but I want to open it up to you guys for questions first and see if there's any questions that I can answer from the audience specific. Yes? Yes. Yeah, so it's like, it's from the non-steroidal anti-inflammatory group. It's called ketoprofen, Ketoprofen. I saw it from the Stanford Medical Center, did a research on it. I do not know if anybody's using it as a standard of care. I was just reading what different lymphatic centers were doing. Okay? Yeah.
When you say the pump, how careful do you need to be about moving the fluid up around the heart?
So it depends on if you have cardiac issues. So I've worked with, so the lymphatic system will deposit the fluid back to the heart. That's actually where it goes to excrete it. It goes through the thoracic duct. It's dumped in the left side of the heart, and then it's excreted through the kidneys. That's normal lymphatic circulation. When I treat somebody who has never had lymphedema treatment before and they have heart conditions, so my non-PMS family people, specifically, I've done tons of like congestive heart failure, things like that are carrying fluid because of heart conditions. I will work closely with their physician to possibly, if I'm going to push a bunch of fluid, because they've never been treated before, I will go super slow, first of all, to push that fluid. And if I'm going to push the fluid, I will actually talk to them about increasing the medication, but then I will expect a huge decrease, probably sometimes even lower than what they were on before, once the fluid is removed, if they're able to maintain that reduction. Because sometimes that fluid is just hanging out, and if we can actually move it and get rid of it, you can sometimes go down. So it is important if you have a heart condition to look at, or if you have fluid that's being retained for other reasons, to look at adjusting your medication. But we do want it to go through the heart to get excreted out. Me first, in the back in yellow.
Do you have a perspective on the use of spironolactone for clearing fluids?
Sorry, can you say it again?
Do you have a perspective on the use of spironolactone for clearing fluids?
I do not know. Is that a medication? No. Sorry? A diuretic. Oh, okay. So thank you. The diuretics, the problem with diuretics are used for multiple medical reasons. If they are used just for lymphedema, we do have a problem. The problem with using a diuretic for lymphedema is you will often go into somebody and they will say, oh, you're puffy. Let's put you on a diuretic. A diuretic concentrates on moving water. So lymphedema is a protein-rich fluid. So what it can do is it can dehydrate the fluid. If too much of a diuretic is used, it can dehydrate the fluid and leave the protein there. Protein will then attract more water. So you actually haven't reduced the lymphatic fluid. You've just taken the water part of the lymphatic fluid away. So, but having said that, depends why you're on the diuretic. Diuretics are also used for renal reasons, cardiac reasons, so it's a balance of the two. And we do have people on diuretics that we treat for lymphedema, but some people will go through the cycle of, it was awesome, I went on this diuretic, my fluid all went away, and then it came back again, or the tissue doesn't feel right in the skin. And if it's only being used to treat lymphedema, it's not 100% effective.
So my daughter's had times when she's had swelling, it's seemingly related to medication. So, and when her medication was changed, the condition went away, and then she'd be try some other medication, it would come back, and so it seemed like it doesn't sound like lymphedema because it seemed to be related to it went away when she stopped taking certain medications.
So something that might help you a little bit, first of all, you can always go and be assessed by a lymphedema therapist, but something that might help you a little bit is it affecting her whole body? Is there a tissue, is there one part of her body that tends to be a little bit more susceptible? Sometime,
It'll be just like one area, like her legs would swell, another parts would not.
right, so if it's always her legs, it is possible that her leg circulation and lymphatic circulation isn't optimal, and so when her system is taxed, that you're seeing signs of lymphedema, it's possible. If it goes away, that's great, but if you wanted to be assessed by somebody that can help you, whenever the system is taxed is when you're going to see the lymphedema worse. One thing I didn't mention on here about primary lymphedema is primary lymphedema comes on at different times. Primary lymphedema will often come on in females, sometimes around puberty. When the hormones in the system is changing because of our body and our physiology are changing. But so there are different things that the lymphatic system may not be optimal, but during certain changes to our anatomy or physiology, then you'll see signs of the lymphedema.
So the test for lymphedema is detected even when she's not experiencing swelling. Is that true or no?
When I assess somebody that doesn't always have swelling, 80% of the time plus, I can tell by their tissue if they have lymphedema. Yeah, yeah, yeah.
My daughter's 30.
Uh-huh.
With very low muscle tone.
Okay.
She has lymphedema that she developed, like you said, at
Puberty.
years.
Mm-hmm.
More in one leg than the other. She was also born with just one kidney.
Okay.
She's been assessed and everything is right with the kidney. Everything else is fine.
Okay.
Except that she has a lot lymphedema in the right and the left, also the torso area.
Yep.
So we're doing the compression garments, the wrap, the Velcro wrap,
Mm-hmm.
the compression machine treatment twice a day, and twice a week the aquatic.
Mm-hmm.
To keep it controlled. And we still see flares. We never seen the red patches or any problems. with
Good.
the
Mm-hmm.
But my thing is, how long, because of she's not able to move too fast,
Mhm.
walk.
Mhm.
She doesn't always want to walk.
Mm-hmm.
So, we go to the physical therapist. I'm not very comfortable because it's very dismissive.
Mm-hmm.
But to me, if I'm doing all those things, this is serious. I mean, this needs more attention. So, how do I talk with them, convey to them, listen, I need something else, or like physical therapy, maybe on the floor area, whatever.
So physical therapy and physical therapy guidelines are tricky. So a lot of times that has to do with insurance wanting a treatment phase and a maintenance phase. So a lot of times I can treat people for flare-ups, give some new advice, help get a rapid reduction, but it won't be a permanent physical therapy. In North America, they want you're treating for a period of time. So I will often see people to look at their garments, help them come up with new things. I have worked with people that will hire a caregiver, and I can help teach the caregiver different exercises and things to do. I'll have people come in and get checked and maybe help with some compression to see if I can reduce their swelling for them. But ultimately, there's a treatment phase and a maintenance phase. And in North America, they won't treat you endlessly, so it's kind of an up and down. But you're right, you absolutely need ongoing evaluation treatment.
What's the best time? I mean, like, okay, she wears her garments.
Mm-hmm.
How long at the period of time during the day? Like 4 hours, 5 hours?
So people can wear compression and 24 hours a day, just taking off for cleaning. It's different types of compression. Some compression is only suitable for daytime use, some is for both. But people wear compression up to 24 hours a day.
Is there a possibility the Phelan-McDermid kids were born with non-working lymph nodes or less lymph?
It's possible that there's less lymph nodes. Possible. Yeah.
I have a son with Phelan-McDermid. He's 22.
Mhm.
I myself have lymphedema.
Mm-hmm.
I was born without my inferior vena cava from my liver down, and
Mm-hmm.
was randomly found out with a CAT scan unrelated to it in my 30s.
Mm-hmm.
But I always had a problem with my legs. Does my son have what I know at 22 at this point? If I don't see any I know if he has lymphedema?
For males, likely yes. Does he have does he have lots of mobility issues or? Oh. So I treat lymphedema. There's a large portion of people I treat for lymphedema. Say when we're talking about the typical population, as people become more immobile later in life, you can have lymphedema just because your lymphatic system isn't working optimally. Sometimes, you know how you get swelling and like varicose veins and, you know, puffiness and all of that. Like the lymphatic system and the circulatory system work in conjunction. So if your circulatory system's getting a little tired, your lymphatic system tries to help out a little bit. So I treat people that just start to get swelling, which turns into lymphedema later in life because of the lymphatic system's tired and not working so well. So that might be more of a secondary type of lymphedema. Primary lymphedema, we do tend to see it. The onset from the research studies are showing an average age of 11-ish, younger-ish, of females, puberty. I say most people have seen it by their 30s, but for our population, I'd be more interested in changes in mobility, that type of thing.
How painful is lymphedema? My daughter's had it for 18 years and she can't tell me. She tells me her legs hurt.
Yeah. So by definition, swelling is not painful. But if you've ever been swollen, it's uncomfortable. Like people will often feel like it's tingly, heavy, irritating. The other thing that we don't know is how much swelling is compressing on a nerve, putting pressure on our muscles. So people tend to, even all different types of lymphedema from different causes, before I see an onset of symptoms where I can actually touch it and look at it, people will sometimes feel that tingly, heavy feeling actually before I see a visual. So they're likely feeling something, sometimes sluggish, sometimes heavy, or if it's pinching on something, then it's probably uncomfortable. Mm-hmm.
Say that after the compression treatments, she usually goes to pee or she has herself
Yes.
really sweaty.
Yes.
So I know it's working.
Yes. Most people, when they see me, they run to the bathroom on their way out of my office. So, like yeah, a lot of fluid works. Anything else? All right. So, just so you guys know, you guys are always welcome. I'm on Facebook. You can email me. You can look me up. I answer questions all the time. I'm happy to help people find certified lymphedema therapists. I'm happy to talk to doctors. Lymphedema, I've been doing this for a long, long time now, over 20 years, and frequently I'm telling the doctors what I would like them to help me with. It's becoming more and more knowledgeable. Often at lymphedema conferences, they'll do a physician day, and the idea is just to get the physicians at the same pace of what's going on. Now I know that some of my colleagues will go and teach in medical schools. I know that for physical therapy training, some of the younger up-and-coming therapists, they actually get a day or a couple lectures on lymphedema. So there's more and more knowledge out there. But often you will be the one asking about lymphedema. They won't go, hey, you have lymphedema. Some do, but often it's your push to do that. Yes? Yes. Unfortunately, that's the hard thing is we, at this point in time, we don't repair the lymphatic system. We treat the symptoms, we try and make it function more optimally, but we don't repair the lymphatic system. Let's see if there's anything else. We talked about the pump. Some people have asked me what kind of accommodations you can have at school. Some people really said, I just had a mom come up to me and say that her child puts up their legs for an hour at school, and that really, really is helpful. Things like if you need your pump to be at school, things like that, you can write into your IEPs or your school requirements, and that has been helpful. The fleshy hands and feet versus what is lymphedema, I say that I would use the help of a healthcare professional to help with that. We do have a different appearance. It doesn't mean we have lymphedema, but if you need that, I would say that you get somebody to help you a little bit. So there's tons of references. The biggest things that I really, like I said, was that cellulitis from the Lymphologists Association of the British Lymphology Society. That was super, super helpful. There's lots of organizations and associations now which have great resources. There's tons of social media. And pediatrics, when I first started 20 years ago, pediatrics was awful at having knowledge on lymphedema. And now it's a lot of the larger pediatric centers will have lymphedema on there. Did you get that? All right. And then here's some more resources. And again, be careful with social media. Some of it's what somebody thinks, and some of it's researched, so just be careful when you're reading through that. And let me see what else I have here. So again, thanks to everybody. The families from the Phelan-McDermid syndrome, that you guys really helped me give the resources. My own child does not have lymphedema, touch wood and all that stuff. But the photos, questions, and contributions of what you guys are experiencing really is guiding a lot of information and helps me a lot even in my own practice. Megan O'Boyle, some of you may know her, she's a parent advocate, and she has a lot of experience from her child having had lymphedema. And again, the whole team here, scientific and the support people, as well as my sister and the board of directors, have been supportive in this talk. And I think that's it. And thank you. If there's no more questions, feel free if you want to ask anything.